This program is brought to you by Stanford on iTunes U at Stanford University. Please visit us at itunes.stanford.edu.
I'm the chair of the Department of Ophthalmology at Stanford, and I have been the chair here for the last 8 years. And in addition to being an academic clinician investigator, I also happen to be a retinal specialist. So this is an area that I do a lot of my clinical work in, so it's near and dear to my heart. So I'm speaking to you as a retinal specialist more than as the chair of the Department of Ophthalmology tonight. And if you're, I'm sure most of you or all of you are very well informed, and you, in addition to being interested in the subject, whether it's related to your own condition or a family member or a friend, if you read the newspapers, you know that there's a tremendous amount of information that's coming out these days, oftentimes on the front pages of some of the major periodicals, the New York Times, the Wall Street Journal. So this is a really big and important area. And as a result, the field is changing so quickly that some of you may know more about it than I do, because I didn't read the paper today. But there's a lot of information. There's a little bit of misinformation as well that's out there. So I'm going to tell you about the field as I see it. I should also disclose to you that I work with many. In addition to working with the university, most of us in academic medicine actually work with many of the companies, typically to advise, consult, and so forth. And so some of the material that you may see is work that may relate to some consulting work I've done, but I'm going to try to provide you with a completely fair and unbiased evaluation of everything I'm showing you. And I think that's really true for all the people that you see who are here at Stanford and elsewhere. But anyway, let me tell you about macular degeneration. So this is the leading cause of vision loss, irreversible vision loss, in the United States, and actually in patients over the age of 65, and in fact in all industrialized nations. It's not the leading cause of vision in the world, because in underdeveloped nations there are other preventable causes such as infectious diseases and trachoma and so forth. But at least for the United States and Canada and Western Europe and Japan and most of the industrialized world, this is the leading cause of blindness. If you look at the American population from an epidemiologic standpoint, there are about 8 million Americans that have some form of this disease in some moderate degree, and about somewhere in the vicinity of about 1.2 million have very severe vision disability, meaning that they're legally blind as a result of this condition, and approximately 180,000 to 200,000 Americans every year develop this condition. And so it's really very, very common, and my guess is that everyone here either knows someone, either family member or friend, that has this condition. And if you look at it, the thing that's interesting about it is that it really is, it is a disease of aging. And so part of the curse, I guess, if you will, of us living longer and living better is that we become prone to these sorts of problems. It's really not a very common disease before the age of 65, but then the incidence goes up very rapidly. And by the time you get to the age of 75 or 80, it's been estimated that in patients over the age of 80, or people over the age of 80, that at least a quarter of the population has this disease. And so it's of importance to all of us as we hopefully live longer and live better to be sure that we can do what we can to be able to either prevent or successfully treat this disease. So I'm going to teach you a little bit about medicine tonight, so you should be able to diagnose this condition if you were good enough to use an ophthalmoscope and look in your friends' and neighbors' eyes. This is a picture of a retina. Here, this is the optic nerve. These are the blood vessels that come out of the retina and supply nutrition to the retina. And then what you see here are what are called drusen, yellow spots. It's a German word. These drusen are the hallmark of this disease. And by the age of 65, about 25% of the population has at least a few of these drusen. Now, if you had this many, we would say that you already have age-related macular degeneration, and this is the so-called dry form or the non-exudative form of age-related macular degeneration. What do we mean by dry? In essence, that there's no leaking from abnormal blood vessels. So patients have this. They may have a little bit of loss of contrast discrimination, or maybe very minimal dysfunction. But for the most part, people who have even this degree of macular degeneration really see very well, and most of the time they're unaware of the fact that they have this disease. So screening and regular eye examinations are really important, because it's like a lot of diseases, you don't know it until the wheel rolls off, and if you did, if you had just been aware, there might be some preventative measures that you could have taken to prevent this progressing. And what these things look like, if you look at them under the microscope, is that they're collections of deposits of lipids, actually. And it's not just lipids from our diet, but the photoreceptors in the retina actually are composed of high concentrations of lipid that are constantly being turned over in response to light activation. And these lipids then have to be metabolized by the pigment epithelium, which is a layer beneath the retina, and digested and then spit out. And what happens is that the retinal pigment epithelium becomes essentially overwhelmed by these lipids, and they pile up and they cause these drusen here. And that's the pathogenesis of that disease. Now, if you're unlucky or you advance to the so-called wet or exudative form of this disease, then the retina looks really quite different. I think all of you can appreciate that there's a very massive collection of yellow material, which is some lipids, also some fibrous or scar tissue, and also some hemorrhage here. And this is really, when people wake up in the morning and they say, oh my God, I can't recognize a face, I can't see the hands of the clock, and I can't read or drive, and this is due to the exudative or wet form. And so this is really the form that has caused 90% of the loss of vision in the United States. Even though this is a lot less common, the wet form of the disease is approximately 10 times less common than the dry form, and typically the dry form progresses to the wet form. So there's a certain percentage of patients every year who have the dry form that convert to wet. But if we could prevent that conversion, that would be a very big thing, a very important thing. Now, if you think about how this happens, it turns out that when you start out, you have these drusen that produce thickening of this membrane that separates the retina from the blood supply to the retina from the underside. And as this thickening occurs, little fissures or cracks develop. And as a result of those fissures or cracks, blood vessels grow up through these cracks into underneath the retina and cause that degree of scarring. And I think you can think about this a lot like the cracks in a sidewalk. You know, normally speaking, lots of living things seek the path of least resistance. And it's very much that way in the retina. As long as you have a strong, intact, what's called Brooks membrane here, and there are no drusen and there are no calcifications, these vessels stay where they belong and they don't cause a problem. But when there are opportunities, they grow up through here like weeds. We think of them very much like that. They're very fast growing, they tend to take over, and they cause all this trouble that we refer to as the wet form. And it's principally because of blood vessels. Now, we did some work a number of years ago. Actually, my wife happens to be a dermatologist, and we speculated that perhaps if we spend our lives processing visual information as a result of light traveling into the eye, perhaps it's the cumulative effects or damage caused by light on the retina that somehow predisposes to this condition. And we put that to the test, and this is, you know, a typical example of clinical research where we took a group of patients that had this disease, and then we compared those patients to a group of patients that didn't have the disease, who are otherwise identical in terms of their age, their gender, their racial background, and so forth. And we took little biopsies of their skin, and we studied not only the skin on the forearm, where it's typically exposed to a lot of sunlight. And I'll just tell you an interesting story. It turns out that, at least in the United States, that the left forearm is always a lot more sun damaged than the right forearm. Does anybody have driving, hanging your hand out the window, or just even having the light come through? And so we corrected for making sure that we had right arms and left arms, and we looked underneath the arm, right under here, where the sun normally doesn't shine. And there are many places where the sun doesn't shine, but that's a good place to look. And the interesting thing was that, of course, everybody had so much sun damage that the effects really washed out between the people who did and didn't have the disease. Everybody had 4+ on a scale of 1 to 4. They were all 5 on the skin, and I happened to be teaching at the Bascom Palmer Eye Institute in those days. But when we looked under the arm, where the sun typically doesn't shine as much, we found that, in fact, there was a dramatic difference between the patients who had the disease and the people that didn't. And it made us realize that either they were somehow getting a lot of sun under their arm to a greater extent than their friends, or that there was some inherent difference in the way that they processed light damage, that they dealt with light damage. And it led us to propose for the first time a hypothesis that said that it wasn't so much that light was important, because that's self-evident. If you don't have any light on the eye, you don't ever have any turnover of the rods and cones, and so it stands to reason you probably wouldn't get the disease. But moreover, the way in which people dealt with light damage, and that's sort of something that you should probably all know from a dermatologic standpoint as well. If you spend your life outdoors and you're fair-skinned and if you're of Northern European extraction, chances are over the course of a lifetime you'll have more sun damage. You'll probably have some more basal cell carcinomas, and if you're unlucky, even a melanoma. And we all know that, and we accept that as an article of faith, and we have the ability to use sunscreen now and to protect ourselves. But there's no way to use sunscreen to protect the eye, at least that way. But there are related ways, and they can be things like sunglasses and just simply staying out of bright environments. And so this was published about 20 years ago, and it languished a little bit in the medical literature. And just in the last year, actually, there's been a lot of data to suggest that in fact there are abnormalities in the way inflammation occurs that are influenced very strongly by genetic factors, and it probably ties all together with the idea that sun damage is important, but that you have to be genetically predisposed to some extent to be able to really, and I'll tell you a little bit about those genes that predispose. So as a result, we really now feel that screening is really important for this disease, because we're starting to develop really interesting and effective therapies, not only to treat the disease, but perhaps to even prevent the disease from occurring to as great an extent as it does. And so I'll tell you about some of those therapies, but they include the use of multivitamins, which we'll talk about, and they also include the use of anti-VEGF drugs such as Macogen and Lucentis that you're hearing about in the paper, and then also some newer things. Now, how do we go about screening patients, and how do we make this diagnosis? So I'll show you some pictures about what we do in the office, and for those of you that have seen an ophthalmologist recently or a retinal specialist, you'll recognize some of the things I'm going to show you. But basically, the very best way to screen for this disease is to do it yourself, and to be aware of the fact that subtle changes in vision can really be a very important marker or indicator of this disease. And the things that we particularly warn patients to watch for are not blurring, because a lot of things can cause blurring, but rather very specific abnormalities in the vision. For one thing, distortion is a very, very reliable indicator of macular disease. So if you look at it, you're looking at a scene that you're always aware of, let's just say the door jamb in your bedroom, or any number of the straight lines on the highway as you're driving, and those features become distorted or wavy, or sort of the kind of a funhouse effect, that's a very highly reliable sign that there's macular disease. It doesn't necessarily say you have macular degeneration. There are some other less common macular diseases, but it almost is what we call pathognomonic, means it's a slam dunk that this is a macular problem. And similarly, if there's a blind spot in the center of the field of vision, if you're looking at me and you could see everything, you could see my jacket and my tie, my necktie, and my hair, but you couldn't make out let's say, the eyes on my face, or my eyes and my nose and my mouth, that's called a scotoma. And if it's in the center of your field, it's called a central scotoma. Scotoma means blind spot. And that's also a very reliable indicator, probably, of macular disease, or in some people it can be glaucoma, but that typically doesn't come on suddenly. So those are some important signs and symptoms that you should be aware of that could lead you to make the diagnosis in yourself, and then in turn lead you to seek medical attention. We also have techniques that we use in the office even if you're not symptomatic. As I showed you before, there are many patients who have the dry form, at least, that are completely asymptomatic, and so we use what's called fundus photography. This is a camera here, a fundus camera, that we use to take pictures of the back of the eye, and we can just take a plain old color photograph, or we can take a black and white photograph, which is monochromatic, meaning one color. Or we can take what's called fundus angiograms, where we actually inject a dye into the arm vein, and the dye travels to the back of the eye, and we can then visualize it. And it turns out that just looking in is very, very, very effective. You don't really have to have a lot of fancy equipment. A physician doesn't, to be able to make this diagnosis. So in this example here, I'm showing you a patient that has some drusen in the eye. And again, we use this term pathognomonic. It means slam dunk. You can see here that in this case here, there's a lot more going on than here. Just you can see the difference between this and this is that there's some hemorrhage in this eye, and that there's even an area where it looks like the pigment might be missing. It looks very yellow compared to here where it's orange. And those are very good signs that that something important is going on. There are some really new and very interesting, you could say almost sexy ways of looking for macular degeneration these days. This is called an SLO, stands for a scanning laser ophthalmoscope. It uses, instead of conventional camera optics, it actually uses a laser to make images of the back of the eye. And these are quite sensitive and very specific. There's also a technique called OCT. We have, in ophthalmology, we're full of abbreviations, you know. And OCT stands for optical coherence tomography, and that's a very sensitive way of actually scanning the eye in a completely different plane and creating the equivalent of a optical cross-section or histology. So just imagine if someone could take an instrument and look at your skin and show you what a pathologist looks at normally after a biopsy. Well, that's very much what OCT does, only it does it without having to make any incision or cut or bleed or anything else. And it's remarkably sensitive and specific. And then there are some ways we look at dyes. This is what an OCT looks like. This is what a camera looks like. So just imagine if you have the capability to look at me. There's lots of different views. There's we call them sagittal and coronal. Radiologists are very familiar with this. But in essence, this is what an angiogram looks like. You're looking at me en face, and if you looked in my eye and you could neutralize all the lenses and take out all the power and just look right at it, facing me as you would, straight ahead, then you would see this is my disc, and this would be the macula, and there's obviously a problem in the macula. If you looked at me sideways like this, and you made a cut through the eye, and then you put that cut under a microscope and looked at it through the microscope, so you were looking at it sideways, this is what you'd see. And this is actually from a living eye, from somebody perhaps in this room, in which we can see some abnormalities, some cysts forming. So these cysts correspond to this leakage here that we see here. So we have a way of looking at the eye in real time without any, you could say it's invasive because we're injecting a little dye, but it's really a non-invasive test that gives us a tremendous amount of information about what the eye is doing. And so these two together are very, very critical. This is just the dye that we inject. Any of you that have been in a retinal office know that we inject this fluorescein dye, and it causes your urine to turn dark yellow orange, and it frightens, and it gives you a nice tan, by the way, for about an hour. And by using this, we can make out lots of detail that we wouldn't otherwise be able to see. And this is how it works. It's sort of interesting. I thought I'd share it with you because it's fun. We shine the light into the eye, and then this eye travels through a filter. And this filter excludes all light except blue light. So the only light that it's entering the eye is blue. And then that blue light activates the dye that has traveled to the back of the eye from the arm vein. And then when that molecule absorbs light, it has to do something with that light. It has to discharge that light, and it does so in the form of photons, or little light particles. But it has an interesting property. It's a fluorescent molecule, and what it means is that it emits light of one color, but I should say it absorbs light of one color, but it emits light or sends back light towards the camera of a different color. So it absorbs blue light, but it emits green light. And then if you put a filter in the pathway of the light going out, it only sees the green light. So there's no reflected light coming back at the doctor, just the light that's fluorescing from the retina, and especially from abnormal retina coming through this green filter. And then we capture that on a chip, or we capture that on film in the old days, or this so-called SLO, and we can see images. And this is another dye that we use called indocyanine green. It has a different wavelength, and it shows us some different things. So this is an example of what a fluorescein angiogram looks like. So here's what the eye looks like taken with a color camera. Here's the same eye, same camera, and although we've applied the filters, the set of filters that I just showed you, and the fluorescein has been injected in the arm vein here, and then the dye travels here, and you see, because there are some abnormal blood vessels here which you can't see and I can't see, and because those abnormal blood vessels are leaky or swollen, the dye accumulates there, and then when we use that special set of filters, you can see it very precisely, because the only light coming back is the light that is essentially emitted from that dye. And the other parts of the retina, for the most part, don't accumulate the dye because they're not leaky and it doesn't shine back. So we can say with virtual 100% certainty that this is an abnormal collection of blood vessels that's causing loss of vision, or soon will, and it needs to be treated. Now, these confocal lasing scanner systems are very interesting, I guess you could say cool, because they don't use lenses. They use a spot of light that actually transfers back, and it uses a computer processor to be able to understand where the spot is at any point in time, so it reconstructs an image based upon the time it takes for the light to get back here, as well as this computer's knowledge of where the spot was sent. So it sends the spot here, 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 and then it comes back here and it detects it. So you get some very interesting pictures. Here's an example here of what it looks like in real time. See the blood vessel filling here? Here's abnormal blood vessels. And here the blood is traveling back. I'm going to show it to you again because it's so interesting. Now watch here, and here's one dye. This is the fluorescein dye here. And this is the indocyanine green dye. So we can actually simultaneously inject two different dyes and get two different parts of information based upon the wavelength of the light, and shows us different information. And you can see this patient here has abnormal neovascularization causing wet AMD. And you can actually see this very specific blood vessel that's filling this area here. So if you could find a way to treat this blood vessel here, or using drugs to cause it to wither away, then you could treat this disease successfully. And you can also use these SLO cameras to show you other things. By using so-called monochromatic light, or light of one particular color, you can get it to reflect back differently. So here's the same eye. Here's using blue light. This is using infrared light, no dyes. This is using a different type of infrared light. This is using fluorescein dye. This is using indocyanine dye, and look at this, they all look like different eyes, don't they? But we are looking exactly at the same eye, same location, and so it's really a very elegant way to be able to extract all kinds of very useful information just by very special optical tricks. And that's part of the sophistication of our specialty, is the ability to use light in very meaningful ways to make these diagnoses. And this just shows you here how the same patient, over the course of 3 years, you can see how these drusen are building up here. And these drusen are white because they fluoresce a certain type of light back at the camera. And so we can follow this. If you were looking at this with the naked eye, or using just an ophthalmoscope, these two pictures would be exactly the same. But by using this specific infrared imaging technique here, we can see how much change there's been between 2000 and 2003. And this is a very powerful way to detect changes even before they're visible to the naked eye, or even to a physician who's using an ophthalmoscope. Another thing we can do with these kinds of images is we can actually montage them together. You know, some of you probably have played around with Photoshop a little bit, or you've seen your friends or children or grandchildren that are good with computer graphics. And it turns out that you can take these pictures and you can actually take 4 or 5 different fields, and you can merge them together to produce a very wide field image here that's a lot more information than you would get from any one visual field. For those of you that have ever used panoramic cameras, you know what I'm talking about, how they differ from conventional cameras. Or you can actually use very special wide field lenses. This is the whole retina here. Notice how small the optic nerve is, and look how beautiful the vasculature of the eye is, and how it all fills from very specific areas. And you can imagine how much information we can obtain from looking at one of these images and trying to make diagnoses. This is another wide field camera that's being used now. It's just being introduced by a company that's based actually in Great Britain that's called the Optos, and I don't have any interest in this at all. But they actually use these cameras on patients in shopping malls and under screening conditions, and they can see almost all the detail of the retina and not only find macular degeneration, which is what this patient has here, but sometimes they can even find retinal detachments and holes and all sorts of other things as well that are otherwise hard to see. So there's a lot going on in the imaging world that's exciting. This is the OCT that I showed you before. It's actually manufactured. It was actually pioneered here in the United States. It was invented at MIT, but it's manufactured by a company right here in the Dublin Pleasanton area called Humphrey. What it does is it produces the optical equivalent in real time in live individuals of this photomicrograph of the retina here. This is from a specimen, you know, from a patient that's passed away, and this is what it looks like under the microscope after you've processed the tissue and done conventional pathology examination. And this is actually a live patient here. It's a different patient, but you can appreciate how you can see all the same details here. And remember, this is 200 microns thick here. So just imagine the degree of resolution that we're seeing. 200 microns is 1/5 of a millimeter. You know, they're 10 millimeters in a centimeter, and they're 2.4 centimeters in an inch. So you can appreciate the level of detail that we're looking at here. And we can make a lot of important diagnoses. These are the kind of images that we see. Here's a patient who has a macular cyst, and you can see this little volcano that's occurred here. And here's a patient that has a macular hole, and you can actually see a hole in the macula here. And probably, I bet you there's more than one person in this room that knows someone or personally has had a macular hole. And here's another picture of a macular hole, and you can see the little divot that's actually been pulled out of the retina. And here's a patient that has what's called an epiretinal membrane or a macular pucker, and you can actually see the little line growing on the surface of this retina here. And this is a patient who has diabetic retinopathy here, and you can see these cysts that are forming in this patient here. And this is another patient here that has a type of condition in which the vitreous jelly is pulling on the retina and producing cysts and wants to, and actually this is an eye that's trying to develop a macular hole, hasn't quite gotten there yet, but probably will soon. And here's another patient here that has macular degeneration, and you can see the swelling under the retina here, a little pocket of fluid, and then all these cysts inside the retina here. And here's another patient here that has a different form of macular degeneration. You can see the pocket of fluid that's accumulated beneath the retina here. This is about 80 or 100 microns resolution. And here's another patient here that has two different types of macular degeneration. This patient here has an elevation of the retina due to fluid, and it also has a little pigment blister. We call that a pigment epithelial detachment. So these are two different manifestations of the same disease, macular degeneration. And we can see that much detail in this eye with these machines. And here's another patient that has a little blister underneath the retina. I want to acknowledge one of my colleagues, Phil Rosenfeld and Carmen Pugliafito, who produced some of those images. This is an example here of some work that's been done by one of our colleagues that we're collaborating with at USC, Dr. Alex Walsh, and he's showing how you can reconstruct the actual image of the retina here, and then you can strip away the layers and show the retina. That's peeling away the retina, and it's showing the pigment layer underneath the retina, which has been elevated. And the thing that's really exciting about this, and this is an area that we're quite expert at Stanford as well in image processing, is that you can use automated methods to be able to show you what's going on. You know, up until now, it's sort of been like being an art historian or an art critic. You have to be able to look at an image and use Gestalt and all sorts of other sort of typical analytical tools that are somewhat subjective to be able to say, well, that looks like diabetic retinopathy or that looks like macular degeneration. With the processing power available in modern computers, and not supercomputers either, but literally laptop computers, it's possible to allow the computer to start making these kinds of diagnoses. Not only make the diagnosis, but say the size of the retina involved is 224.79 square microns, or the volume of the blister of fluid is so many microliters of fluid, and in response to your treatment, your volume has decreased to 142.3 microns, and so I think we're going to treat you today, or I think we're not going to treat you today, based on that type of information. So it's incredibly powerful and enabling. This is a patient here that has macular degeneration and that we have seen at Stanford. I've done a lot of work, the department has, with Dr. Doug Vollrath, who's a wonderful geneticist in the Department of Genetics here, and we're very, very interested in the genetics of age-related macular degeneration. Why does this run in families? And there's a lot of data to suggest that if you have and people always ask me this question, and it's a hard question to answer because it's not the answer everybody wants to hear, but if you do have a family member that has a close relation, in other words, a son, daughter, parent, sibling, and so forth, there's a much higher likelihood, there's not a certainty, but there's a higher likelihood that you will either have the disease or you will transmit that disease. And so we know that there's a certain amount of genetic predisposition, and it turns out that the genes are now being identified at a very rapid rate that we know cause this disease. This is a disease that comes on in the 30s and 40s, and so we studied this patient and with Dr. Vollrath and Dr. Ruth Lynn here and myself, and this is work that will be published shortly later this year, in which we identified a new gene that causes a disease that for all practical purposes is exactly like macular degeneration, except that it comes on much earlier in life, in the 30s, 40s, and 50s, rather than the 60s, 70s, and 80s. And so as a result of that, it gives us a lot of insight into some of the factors that lead to this condition occurring. And you can see the blood vessels that are growing right here and right here in this patient. And it turns out that it's in a gene called TIMP3, which is on chromosome 22. It's the smallest of our 22 non-sex-related chromosomes. You know, we have 22 pairs of chromosomes, 44, and then we have an X and a Y or two X's, depending on whether you're a male or a female. And they're grouped, 1 is the largest chromosome and 22 is the smallest chromosome. And it turns out that this particular gene, which is very reliably produces this disease, is on chromosome 22, the smallest chromosome. And the other and this is a relatively uncommon gene. The really common gene is actually called complement factor H, and that's found on chromosome 1, the largest chromosome. But this chromosome, we identified this one, and we found a very specific mutation. And as many of you know, DNA is composed of pairs of bases that are in a double helical strand. And if you just have one single base pair difference, and if you substitute an adenine molecule for a guanine molecule, it turns a particular amino acid histidine to arginine, and as a result, in this case, it's the arginine is the normal one, and it becomes a histidine. And as a result of a single amino acid, in a single protein, out of the hundreds of thousands of proteins and literally millions and millions and millions of amino acids in the body, that's enough to give you this disease. And so, knowing that, it gives us the opportunity to be able to look at ways to treat it. And this is what the molecule looks like, and the only difference is that this one single amino acid here out of this entire molecule is different, and that's enough to cause a disease. So it's really important in terms of not so much whether or not treating this disease and this particular disease, which is somewhat rare, is going to change the fate of the world. It won't, but it does change our understanding of what causes disease, because we know exactly where this molecule resides. It happens to sit in that membrane that separates the pigment from the blood vessels. And so we know it's a valuable clue that says that it's probably not the photoreceptors themselves, it's probably not the blood vessels themselves that are abnormal, it's this membrane called Brooks membrane that separates the pigmented cells, the pigment epithelium, from the choroid or the vasculature that causes this problem. And if we could find drugs or other ways to keep that membrane nice and thin, and I remember I showed it to you earlier, the one that gets thickened and cracked and calcified, then it would be possible to probably prevent much of this disease. Now, I'm going to move on to the therapeutic side of my talk for the second half, and to finish up. It turns out that there's been an enormous explosion of knowledge about what actually causes the wet form. What I just showed you is a very tantalizing clue into what causes the dry form. And we know that typically speaking, you start with the dry and then you convert to the wet. So that particular gene I told you about, the complement factor H, caused a big stir. Earlier this year, there were 3 simultaneous publications in probably the most prestigious American science journal called Science that all found the same gene at the same time. Now you might say to yourself, isn't that interesting? What a coincidence that they all found it And of course, there probably was a certain amount of talk going on. But at any rate, the journal was good enough to publish simultaneously the work of 3 different independent laboratories, or it was actually more labs, but 3 different groups that were collaborating. And so we know that about half of macular degeneration is probably caused by abnormalities in that same gene. Now, the interesting thing is that that's a very common gene. So half of patients who have the disease have that gene, but interestingly enough, about a quarter of the population also has that gene. So all that gene is necessary but not sufficient to cause that disease. And in fact, it raises questions related to lifestyle. Do you smoke? Do you eat a diet that's rich in lipids? Do you have abnormally large amount of light exposure and so forth? But it really raises a lot of interesting issues about how you have to work with your genes. And none of us can choose our parents, and therefore we can't choose our genes. And so we have to work with the cards that we're dealt. But there's a lot you can do with a bad hand if you know that you have a bad hand. And the hard part really is knowing that you have those cards. Now, the other thing that's really interesting about this disease is that once you convert from the wet to the dry to the wet form, turns out that there's a very well characterized sequence of events that occurs. What happens is this molecule right here, VEGF, which stands for vascular endothelial growth factor, is secreted in fairly large quantities. And there's a trigger that causes this VEGF to be secreted. And we didn't understand for many years what that trigger was. And we sort of know now that it has to do with inflammation. And that's surprising because I don't think any of us really thought for a long time that this was an inflammatory disease. We thought of this as being a disease that was more like atherosclerosis or hardening of the arteries. But it even turns out that perhaps hardening of the arteries is, in many ways, the byproduct of years of low-grade inflammation, too. So this molecule, VEGF, is really important, and this is the thing that causes it, that takes a normal blood vessel and turns it into a quiet blood vessel, turns it into a rapidly growing molecule. What happens is this VEGF here is secreted by various cells. This is an inflammatory cell here. This is the retinal pigment epithelial cell that I showed you before, that if you stimulate it. And this is actually a neural cell here from the retina. And any of these 3 cells, if they're sufficiently provoked, and that's exactly what it takes, is it takes provocation. You have to provoke it with some sort of a stress, thermal stress, light stress, inflammatory stress, you name it. If you stress these cells, they will, in response to that stress, secrete this molecule, this VEGF molecule. This VEGF molecule then sort of migrates over to a blood vessel, which is sitting around minding its own business, doing its job, not bothering anybody. And the simple activation of this blood vessel by this molecule turns it into sort of a monster. And instead of sitting there doing nothing, all of a sudden it starts to send out little sprouts, which are called neovascular sprouts here. It also becomes leaky. And instead of keeping the blood column and the serum and all the components inside the vessel wall, they start to move through the wall as a result of a couple of different features. One is called the loss of the so-called tight junctions. These tight junctions are special properties of cells where they're essentially glued together and they're watertight. And you can imagine if you had any type of a bag that was watertight and it stopped being watertight, you'd have all this leakage and fluid buildup, and that's what happens. And there are also these little special compartments called fenestrations, which are little holes in the wall, in the cell wall itself, not between cells, but actually in the wall of the cell. And we think that these are probably actually necessary in certain parts of the body to promote the health of the body. So it's an interesting situation whereby what's good in one part of the body is bad in another part of the body. The other thing that you may hear about a little bit related to this VEGF molecule is the role of steroids. Now, steroids are a big topic. You know, we read about baseball players that are taking anabolic steroids, and we read about weightlifters, and you hear about people using steroids for all sorts of things. But it turns out that one of the things that steroids do, besides actually causing bulk or secondary sexual characteristics in the case of the sex hormones, which are also steroids, is that they actually inhibit the growth of blood vessels. And so it turns out that if you are an organic chemist or a biologist, you can tweak these molecules in very specific ways and use these steroids to actually inhibit blood vessel growth. Now let's go on to actually what are the molecules that work. Now this is a really important slide, and yet it's overlooked all the time. You know, for patients that have the dry form of macular degeneration, people always say, well, there's a lot of work being done on the wet form of the disease, but nobody's working on the dry form of the disease. And that's actually not true at all. Turns out that it was a really landmark study that was performed, that was published now about 5 years ago, and it was started about 15 years ago, in which over the course of 10 years, the National Eye Institute paid for about 3,500 patients to take one of several different groups of regimens using multivitamins. Now, what are vitamins? Vitamins are essentially cofactors that are not necessarily found in great quantity. You don't normally eat all vitamins, and depending upon your eating preferences, you might be rich in some and light in others. So what vitamin manufacturers do is they take all these essential cofactors, which really are required to have normal enzyme activity in the body, and they supplement them into a single pill. And it turned out that several vitamins are very important in terms of preventing oxidative damage. What is oxidation? Oxidation is basically rust. So if you leave metal, iron in particular, outside in the rain or exposed, obviously it turns orange, and that's rust, and that's oxidation. And that's very much what occurs in the eye, is that you essentially get rust buildup. And if you were to use an antioxidant, and for those of you that eat in salad bars, you know that they apply antioxidants to lettuce leaves to prevent them from oxidizing and turning brown even over the course of several hours at the end of the evening. And so that's what some of these molecules are. Beta-carotene is an antioxidant, and vitamin E or alpha-tocopherol is an antioxidant, and zinc even has some antioxidant activities. But anyway, if you add beta-carotene and zinc and vitamin E and vitamin A, which is found in fatty foods, and you compare patients who take these vitamins and who have the mild forms of macular degeneration, the dry form, and you compare them over the course of 5 years and 7 years to their peers who are not taking them, you can reduce the progression of the severe form of this disease by 38%. Think about that, how important that is. If you've got 1 million Americans or 8 million Americans that have the early forms of this disease, and you can reduce the rate of progression of those 8 million Americans by 40%, well, that's 3 million people that can be benefited by this. And if you break it down by year and you divide that by 7 years or so, you can see that every year you could probably benefit 300,000 or 400,000 Americans by simply taking these multivitamins. Now, I have no interest whatsoever in any of these compounds, but you can get them over the counter, and they're not prescription items. And anybody here who goes to an ophthalmologist who has any of these drusen, if you're not hearing from your ophthalmologist that you should be taking vitamins, then you need to find a new ophthalmologist, because the data is very clear, and it used to be very debated, and in fact it was controversial. And people said, oh, people are spending money on vitamins and they're not any good, and so forth, and it's a waste of time and money, and that just isn't true. So you have to first, of course, you have to have the earliest signs of this disease to have the benefit, we think, but we don't really know. What if everybody who was 35 years old who didn't have any drusen at all and whose parents both had macular degeneration, what if they started taking these vitamins at age 35? And then you fast forward 30 years into the future and you have 30 years of protection using antioxidants. Common sense suggests that probably would be a beneficial thing, assuming the vitamins were safe. Now, there's sort of a catch to this, and that is that not all vitamins, not everyone agrees that these vitamins are safe, and there's been a little bit of press, and some of you may have read this, where there's a concern about whether vitamin E, in fact, can cause cancer or actually heart disease. And some people worry that beta-carotene, which is an analog of vitamin A, if it's taken by a smoker, a former smoker, or particularly a current smoker, may actually increase the risk of lung cancer. So I don't want to present this as totally straightforward, black and white. It's not, and there's no such thing as a free lunch. Every drug potentially has a benefit and also a side effect, and so you always have to weigh these things. But as a general principle, vitamins are pretty darn safe, and that's why they're non-prescription items, because there's not that much potential for harm. But you have to be aware of those couple of caveats I told you about. These are called, these molecules here are called porphyrins. I don't know if anyone familiar with the play The Madness of King George, and are familiar with what his problem was and why we might even be a country, is that King George, of course, during revolutionary times was felt to not be entirely of sound mind, and he would have these fits of delusion and lunacy, and it was felt that the royal family English royal family, because they were so inbred, were more prone to a variety of genetic mutations, and one of which was porphyria. And so it's been long known for more than 200 years that patients who have this so-called porphyria were very, very light sensitive. And if they went out, especially in the bright sun, they sunburned very badly, and it became so painful and disabling that they acted crazy. And there's actually there's a Nicole Kidman movie as well called The Others, in which the children, I think, have porphyria. But the point about the porphyria and porphyrins is that these are photosensitizing molecules that are made in the liver, and it turns out that you can use them for benefit as well as cause harm, and it's like lots of other things. And so it turns out if you inject these molecules, especially benzoporphyrin here, which another name of which is Visiodine, and then you activate it with a very low intensity light, actually an infrared light, it actually will damage abnormal blood vessels and it will spare normal blood vessels. So it's a kind of really elegant situation where the drug accumulates preferentially in abnormal vessels and it spares normal vessels, and that's called photodynamic therapy. And photodynamic therapy was the first really major advance in the treatment of age-related macular degeneration, and this occurred about 4 years ago. We were actually the first site on the West Coast to do photodynamic therapy here, and this is an example here where it shows you this little dark circle that occurs when you activate the dye, and you'll recall that abnormal blood vessels, of course, are very white, so you want to go from white to dark here. And the beauty of photodynamic therapy, unlike other types of therapy, was it didn't damage the adjacent retinal layer, so it's a very highly specific therapy, and this has been the mainstay of therapy in the United States for the last approximately 4 years. I think the drug was approved in 2001, if I'm not mistaken. And so it's been used for about 4 years, and I know some of you here have actually had this therapy. And this is just a graph that shows you that if you compare the patients who were on placebo here to the patients that received the photodynamic therapy here, and this y-axis here is the number of patients who lost vision and lost a certain amount of vision, you can see here that the yellow is consistently higher than the green here. This difference is not huge, but it's significant. It's certainly statistically significant. And so patients who received Visiodine therapy in this very big study were more likely to do well at 12 months and also at 24 months than those that didn't. And so this ushered in the new era of pharmacotherapy or pharmacologic therapy for macular degeneration. Now, what we found is that this wasn't a very good therapy, but based on work that was done in New York and also at Stanford, which we've been very active in, we've been able to show that if you actually add a steroid to the Visiodine, which we didn't initially anticipate, that it dramatically improves the outcomes. And so the combination of Visiodine plus a steroid, remember we talked about steroids being anti-angiogenic, in other words having properties that inhibit blood vessels as well as being anti-inflammatory, then combining the two together really produces what we call synergy. The net effect is greater than the sum of its parts, and that's a very powerful technique, and so that's been a very successful therapy for us, and we've been using this for the last 3 years or so. This is a molecule here called pegaptinib, but it goes by a name that probably almost everybody here who's interested in macular degeneration has heard of. It's called Macugen by a company called iTech in New York, and they were the first to introduce this drug for patients, and this just shows the graph here of patients who had Macugen here compared to patients. Now this graph is exactly the opposite of the last graph I showed you. In this case, the yellow line here is good, meaning that this is the people, how much vision they retained. Here's the group here that were not treated, and you can see here there was a progressive loss of vision over 1 year and then again over 2 years in patients who were randomized. Now, for those of you that have been patients at Stanford or elsewhere, you know that we do these clinical trials all the time, and one of the things about clinical trials is that in order to show that something works, you have to prove that it works better than not using it, and that means that somebody in that study has to not get the drug, and of course that's the placebo group. So in a sense, it's one of the necessary evils of clinical research, and it's one that I personally struggle with ethically. How do we find appropriate controls so that and protect people who are randomized in these trials to not receive the drug? And so there are lots of safeguards in place. There are things called data and safety monitoring committees that are constantly monitoring the data. So if it becomes abundantly clear that a drug is very, very effective, they will terminate a trial early and let everybody in the trial know that, you know, this drug is working so well, we can't even go the full year or the full 2 years. We're going to stop the trial now and make it available to everybody. And conversely, these Data and Safety Monitoring Committees, or DSMCs, are watching like hawks to be sure that these drugs are not harmful. And if the committee sees that all of a sudden, and they're not masked, everybody else is masked. So when your doctor, if you go in and you are part of a clinical trial, and I would encourage all of you that have diseases that would be benefited by the study from doing that. Hopefully, if you're lucky enough, we've already got all the answers for whatever problem you have. But if we don't know, we do these trials. These committees are always looking over the data, and if there seems to be any potential for harm, that's the thing that these committees monitor. And the point I wanted to make to you was that your physician typically doesn't know what drug you have. Not only do you not know whether you're in the placebo group or the drug group, but your physician typically doesn't know, and that's one of the basic tenets of good clinical research, is in order for there to not be bias, or for people to not be, if you will, cheating on trying to get you to see a little better if you're the drug patient as opposed to the non-drug patient, then no one can know, and everything is done by a sealed envelope. And so, but these data and safety monitoring committees are not masked. They are aware, and they're prevented and prohibited expressly from talking to the physicians. But if they see a problem, they pick it up. And so I just want to reassure everyone in the audience that there are, you know, more than adequate safeguards in place that make this a very useful and ethical thing. Now here's the latest and greatest news, I guess. And I again don't have any interest in this particular molecule, but although Stanford was the first site on the West Coast to use this molecule, it's a drug that was developed by Genentech just up 101 a couple of miles. And it's both Lucentis and Avastin are really derived from the same molecule. What Genentech did, which was particularly brilliant, I think, is as you know, they specialize in recombinant technology that, in fact, was pioneered by researchers at Stanford, Stanley Cohen, who's here on the faculty, and also Herb Boyer at UCSF. And the company was based on the ability to basically link chains of nucleic acids together, produce the proteins from those nucleic acids. And in the case of this particular class of molecules, these are so-called monoclonal antibodies. These are antibodies that are directed specifically against that molecule I showed you before called VEGF. So as a result, logically speaking, we call them anti-VEGF compounds. And the other molecule I showed you, the macogen, is also an anti-VEGF compound, but it's not a monoclonal antibody. And for a couple of years, there was a very vigorous debate in the scientific literature amongst physicians. It was reported in the press, where they were both targeting the same molecule. They were both targeting VEGF, or vascular endothelial growth factor, but one was using a non-antibody approach, and Genentech was using an actual antibody that was raised in cell culture, essentially. And what they did is they did two things that are really interesting, and I'll tell you the story because it's sort of fun, and it's just kind of a modern mystery, actually, whereby they produced this molecule. Now these molecules are typically composed of three fragments. There are two arms. It looks like a Y, and the two arms are called the FAB fragments, which is the if you will, the binding site for the molecule against the VEGF molecule. So it'll actually bind two VEGF molecules, not one. And this is called the FC fragment here. And this is what stabilizes the molecule when it actually binds complement. Now it turns out that because this is a much larger, bulkier molecule, it doesn't travel too well through the retina. And as a result, it was predicted, this is all theoretical, it was predicted that this molecule wouldn't be all that good if you injected it into the vitreous cavity, because it was thought that it was a little too large, and even though it would bind the VEGF, it wouldn't get to where the VEGF was causing problems. And so Genentech actually went to the trouble of breaking this molecule up, and they broke off these arms, and they broke this off. So instead of this being a very large molecular weight molecule, about 150,000. The metrics don't matter, but just they broke it down into a molecule that was 1/3 that size, a single arm here, and that's what this looks like right here. And this is Lucentis, and this is Avastin. Now, Avastin was put to the test, and Genentech had to make a decision whether to test. Like all companies, they were they were trying to decide what is the highest and best use to put this molecule to. So they used this molecule here after a lot of internal discussion to test it against colonic carcinoma, particularly advanced forms of colon cancer. And they proved that Avastin was effective, and as a result, the FDA recently approved Avastin for the treatment of advanced forms of colon cancer, and it's made a big difference in the lives of many people. It's not a cure, but it prolongs life, and it definitely is beneficial. Meanwhile, by taking the time to break this molecule up and to create the smaller fragment called the Rufab here, or Lucentis, it cost them about 2 or 3 years of development time. And so this wasn't actually tested in humans until about 3 years after they started the Avastin trials. Meanwhile, the other drug I showed you, Macogen, which also acts against the same VEGF molecule, went through a rapid sequence of testing and was then approved by the FDA, and it's been used for about the last year or so, a little less than a year. Meanwhile, but the results were good, but they weren't great. They were similar to the results we were seeing with Visidyne. So people said, well, that's good. We've got another drug that works. It doesn't dramatically improve vision, but it does seem to slow down the rate of loss of vision, and so that's good. You know, it's like the old story. It all depends on your point of view. Is a drug beneficial? Well, if it makes you live longer, it's beneficial. But if it makes you perfectly healthy, then that's better than just being effective. It's something else. And that turned out to be what happened with the Lucentis. Lucentis data was released this year in April of this year, or May, I guess it was, and then it was re-released again in July. So we're only talking 6 months or so. And it turned out that this drug was dramatically better. The Lucentis drug was dramatically better than the other drugs. And so instead of 5 or 7% of people having significant improvement in vision, and the principal benefit being a slowing down of the loss of vision, about 30% of the patients who took the drug actually had a dramatic improvement in vision. So that was a real watershed. And instead of 2/3 of the patients having relative stability of vision, in other words, less loss, 95% retained their vision. And so those were not subtle differences. Those are very substantial differences. Well, that sounds like a great story, right? What's the problem? Well, the problem is that once the study is released, you still have to go to the FDA, and the FDA is a thoughtful, careful body that regulates the safety and the availability of drugs. And it turns out that even after the publication of trial results, that the FDA still does its homework, takes time, and checks with the manufacturer, and does a whole series of checks and balances. And as a result, typically a drug, even after safety has been demonstrated in a scientific journal, is not approved for between a year and sometimes a year and a half, just to get the label right, the manufacturing right. So here we have a situation where the ophthalmic community and all of the patients are aware that the drug is effective, and yet it's not available. So what do? Well, a very clever guy at the University of Miami, Phil Rosenfeld, said, well, maybe if Lucentis works, maybe Avastin will work too, even though it wasn't designed to do the same thing. And so Phil, starting in May of this year, started injecting patients in a sort of a brave way, really, with Avastin. And what he showed was that it seemed to be, and we still don't have all the data, and so what I'm presenting to you is very late-breaking news that has not been yet subjected to the rigor of peer review, but nonetheless, a lot of oral presentations, a lot of anecdotal experience that suggests that Avastin is, at least in some ways, more like Lucentis than it is like the other therapies, and it's available because it's approved by the FDA. And what physicians are doing is they're starting to actually have it prepared by pharmacies and injecting it even though it's not approved. Now, that is a technique that's been around a long time. It's called off-label use. It's not expressly prohibited, although it's not encouraged by pharmacies and by the government. And so it's created this very interesting dilemma for Genentech, because here they have one compound that they've gone to a lot of trouble to get approved for one indication, and then they have another compound which is related but not the same, which they've spent a lot of time and money working on, which is just about to be approved. And here they're finding that physicians and patients are demanding that they use Avastin now, at least until such time as the Lucentis is available. And if you read the New York Times or the Wall Street Journal, you've probably seen a number of articles about this, because it's really created a kind of a dilemma for ethicists and for pharmaceutical companies and for physicians. And the answer is, what do you do? And none of us know, because we're all struggling. This is the first time anything like this has happened before, and so I'm sure that there'll be a lot more that you'll be reading about it. But in the meantime, this drug seems to be working quite well, and we're anxiously looking forward to having Lucentis available, which is an approved drug, and in the meantime, different physicians are handling the Avastin problem in different ways. So I want to summarize by saying that there are lots of exciting things happening in the area of macular degeneration. We've just in this year alone, to give you an idea, in the last 6 months, the major gene's been identified, and a dramatic watershed breakthrough drug has been identified that really, and I mean Lucentis, and I don't mean Avastin necessarily, but Lucentis, and those two things alone represent a larger change in our understanding and our treatment of the disease than probably the last 30 years combined. So the pace of technology change is very rapid, and I suspect that we can't have those kind of blockbuster years every year. That's just too much to hope for, but it does suggest that because so many people are working and because so much more is known now than was known 2 years ago, 5 years ago, 10 years ago, that we're likely to see a continuing rapid pace of knowledge advancement and effective therapy. So I personally feel very, very optimistic that we're at the dawn of an era where we're going to be able to really make a big dent in this disease, and probably we're going to see other diseases that are now listed as the leading causes of blindness in the United States, because this one will probably drop at some point, I hope in the near future, from being the most common, not because we all don't carry the gene for it, but rather because we have such effective ways of diagnosis and treating it. So I think I'll stop my remarks at this point, and we're running a little bit late, but I will take a couple of questions if you want to hang around, and thank you very much. The question was, am I talking about wet treatment or dry treatment or both? So I showed you two different ones. The first one I showed you, the vitamin therapy, which is the ARAD study, which is antioxidant, multivitamin, zinc, beta-carotene, and vitamin E, and so forth. That's for dry, okay? The one I just showed you, the Lucentis and the Macugen, which is still very effective, although not quite as effective as the Lucentis and also the Vigidine, those are for wet. So that depending upon which stage of the disease you have, there is a therapy that is available. The gentleman asked whether or not transition, I'm assuming you're referring to photo gray glasses that darken when you go outdoors, are they as effective as regular sunglasses in protecting people? And the answer is probably not. And the reason is that it turns out it's not just enough to darken to put in what we would call a neutral density filter or a gray filter. It turns out blue light is more damaging than green light or yellow light or red light. And so you want to selectively filter out blue light if you can, and those glasses don't selectively filter out blue light. They get rid of ultraviolet light, so they're good. But if you want to wear the very best sunglasses to protect against the progression of macular degeneration, then you should use what are called blue blockers. Now that doesn't mean that they look blue. In fact, they don't look blue. They look yellow or orange or amber. As you know from your color tables from school, your school days, that those are complementary colors. So things that block out blue look yellow or amber, and that's the best color to use as opposed to the photograys. Photograys are fine if you in a pinch, but you really, for anyone who has this disease, you really want to be wearing blue blocking sunglasses. Plus, they also sharpen your vision very slightly because blue light scatters the most. The question was, what about lutein? Lutein is a naturally occurring antioxidant that's found in things like spinach and kale, green vegetables, squash, so forth. And lutein, there's a lot of anecdotal evidence and a lot of sort of retrospective evidence from dietary studies that suggests that lutein's protective. Lutein's part of the macular pigment. So there's going to be a very big trial by the same people that put on the AREDS trial, and they're going to specifically study lutein, and they're also going to study omega-free fatty acids, which are the fish oils, as well, because there's a reason to believe that those antioxidants are also protective not only against heart disease but macular degeneration as well. So I think there's no harm in taking lutein. Lutein's a pretty safe drug, and in fact, one of the vitamins that you can get, the so-called Ocuvite Preservision or the eye caps, those are the two competing large vitamins. They both offer a variant that has lutein in it. You can go out and also buy lutein in the drugstore. I usually tell patients that I see no downside to taking lutein, and most of them take it as well. But it's not. But I should tell you, it's not proven. It's never been put to the same rigorous test that the other vitamins were, and they were proven to be effective. Lutein is still speculative. The question is there a relationship between cataracts and macular degeneration? Yeah, there's sort of two opposing forces that are probably at work. In a way, a cataract is a good thing against macular degeneration in the sense that it blocks out a lot of the light that gets into your eye, but the price that you pay for that is not seeing well, so it's not worth it. On the other hand, cataracts can be a marker. We all get cataracts if we live long enough. So when you get into your 70s, 80s, and 90s, basically everybody has a cataract. But a cataract very early in life can mean that there are some basic physiologic issues with the glucose metabolism or other things. And so it can be a marker for macular degeneration, but there's not a strong correlation, no. One thing that's worth mentioning, however, between cataracts and macular degeneration is that if you have underlying macular degeneration that you're not aware of, and you're having visual difficulties, and you're going to an ophthalmologist who doesn't carefully examine the retina and says, oh, I'm sure your problem is due to the cataract, they take out the cataract and then it turns out that there's macular degeneration there. Sometimes they're blamed, the physician is unfairly blamed for causing the macular degeneration, whereas in fact the macular degeneration preceded the cataract, or in fact was the real problem to begin with. There is a little bit of evidence to suggest that if you have the disease and you have cataract surgery, it may slightly activate the disease, the wet form, not the dry form, but the wet form. But there's not a really strong correlation between cataracts and macular degeneration, except that they're both age dependent. The question was, how is Lucentis administered and what intervals? Well, I'm not going to show you the video because you won't like what you see. It's administered as a shot, and the shot is given actually into the eye. And now it sounds terrible, and if any of you saw the Salvador Dali movie La Chienne Andalou, the Andalusian dog, you know that to make a point, a surrealistic point, they actually show an eye being incised, and that caused a scandal in the 30s or 40s. But it turns out that with modern technology and tiny little needles, it's really a very minor thing to give these shots. But I think the thought of it's a little frightening to patients, but you shouldn't be frightened. Secondly, in terms of the frequency, nobody knows precisely what the best or what the optimal frequency is. The protocols all call for, the early protocols called for Lucentis to be administered once a month. We think that's probably more than you need. So there are several trials that are looking at less frequent administrations. Macugen, which is the pegaptamid, is given every 6 weeks. And there's a specific trial now being conducted by Genentech where they're giving 3 injections, 1 a month, and then 1 every 3 months after that, sort of using a loading dose technology. So the answer is that to some extent it depends on how the patient's responding. And what we have the capability to do, remember I showed you at the beginning of the talk all those fairly elegant and sophisticated screening technologies that allow you to know exactly what's going on. So based on how the angiogram looks, you can make it doesn't have to be so cookbook, add salt, add sugar, add, and so forth and so on. You can base the treatment decisions on sort of more of a real-time evaluation using angiography and OCT as to how things are going. The question was, is there a way to look for the inflammation that might predispose to this? Is there a test you can do? And people have used a variety of, it's not enough just to look at white blood count. One of the things we found actually in my study from 20 years ago was that patients with white blood counts tended to have statistically higher, patients with macular degeneration had statistically higher white blood counts than those without, but they were both within normal limits. Now it turns out there's a marker of inflammation called the SED rate, which is the old way, or now it's called C-reactive protein, or CRP. That's a very sensitive indicator of sort of low-grade, how much low-grade inflammation you have going on in your bloodstream at all times. And there's been some data to suggest that the patients who have elevated C-reactive protein levels are more likely to get macular degeneration. By the way, they're also more likely to get heart disease. And by the way, Lipitor and those other related statins lower C-reactive protein independent of their effects on cholesterol. And so there's a lot of thought that statins may possibly be another drug that could reduce the likelihood of macular degeneration. And there are some studies going on right now, but there's no data from those studies that I think is reliable enough. The studies that have gone back in time and looked at it retrospectively have been inconclusive. Some of the studies have shown a benefit of statins, and other studies have not shown that benefit. But the C-reactive protein is probably a good thing to have measured in general by your doctor, because it may be a marker for all sorts of problems that are related to chronic low-grade inflammation. Light sensitivity related to macular degeneration. Yeah, to an extent it is, yes. Patients who are, we know from epidemiologic studies that people who are, let's say, Swedes and Danes and people of Northern European extraction have a much higher incidence of macular degeneration than people who are more heavily pigmented. For instance, the exudative form of age-related macular degeneration is extremely rare in Africa. It's very, very uncommon. And no one knows exactly why. People have speculated that it has to do with the fact that if you have more melanin not only in your skin, but in your choroid, in the retinal pigment epithelium, it soaks up the extra light and prevents essentially light damage. So people who are more prone to sunburn, you know, of English Irish extraction, Scandinavian extraction, those patients have been shown statistically to be at greater risk. And it's, for instance, and there's a simple marker for it: are you blue-eyed or brown-eyed? If you're blue-eyed, your risk of having macular degeneration is higher than if you're brown-eyed. The question is, can Avastin be used at the same time as Visidyne? So let me answer that, and let me take an extra second to answer it. You might ask, well, why would you want to have multiple different drugs if one's so good? And the answer is because sometimes it takes more than one. You have to attack, it's like, you know, an army invasion. You have to attack from multiple fronts to be effective. So yes, we think that Visidyne is primarily a physico-mechanical effect, where you're actually shutting down the capillaries using energy, and whereas Macugen or Avastin are essentially biochemical mediators, where they actually, remember those fenestrations I showed you and the junctions that became leaky? Well, though it looks as though Avastin acutely basically seals up those junctions, or Lucentis, shall we say, seals those up. So on the one hand, you have something like Visidyne shutting down the whole capillary itself, and then these other molecules like Lucentis. But they haven't been put to the one study that was done. There was one study done where they actually combined Visidyne with Lucentis, and they didn't show a lot of additive effect. So in other words, the patients who received the combination of Lucentis plus Visidyne didn't do a whole lot better than the patients who received the Lucentis alone, but they happened to be using, as it happens, an older version of Lucentis that was prepared in a different way. And so most people think that that study was sort of flawed, and we can't assume that they're not additive. But most of us who are in the field think that additive effects and combination therapy, sort of like chemotherapy, is going to be the way that we treat these diseases in the future. But there still is limited data on the additive effects of those two agents. The gentleman is asking about a drug from a company called Genera, which is squalene. Squalene is made from shark fin, and as you know, shark collagen is relatively free of blood vessels, and so they reasoned that perhaps there was something in the cartilage that was preventing blood vessels from going, and that turns out to be squalene, which is actually a form of a steroid. It's being put to the test. The preliminary data suggest it may be effective, although the preliminary data doesn't suggest that it's likely to be as effective as Lucentis, but it has. But I don't want to say that because all the data hasn't been released yet, and the study's still going on. But it's a drug that, one thing that's interesting about that drug is it's administered systemically rather than as an injection into the eye, and so that might be appealing to some people that don't want to have the injection. The question is, when is Avastin going to be available to the general public? So the answer is now and never, probably at the same time. It's unlikely that Genentech will do a regulatory trial for Avastin in the near future, at least, because they already have a drug that's very, very similar to Avastin that they put to the test and was successful and will be released soon. So in theory, if you take away the issue of economics, meaning how expensive is Lucentis versus Avastin, there's probably no reason to use Avastin a year down the road when Lucentis is available. Now, Now, somebody else may test Avastin, and that's an interesting question. Good question. We weren't talking tonight about diabetic retinopathy, but just to put it in perspective, diabetic retinopathy is the leading cause of vision loss under the age of 65. So under the age of 65, diabetic retinopathy. Over the age of 65, macular degeneration. And it turns out that many of these same molecules and techniques, the diseases are different, but they are both linked together by the fact that VEGF is important in both of those diseases. So these same classes of compounds, especially the anti-VEGF agents, Macugen and Lucentis and possibly Avastin and steroids, all play an important role in diabetic retinopathy as well. But if you have diabetes for many years, you don't get macular degeneration, you get diabetic retinopathy. And in fact, there's even some minor thought that diabetic retinopathy might in some peculiar way protect you a little bit against macular degeneration, but it's certainly not worth having for that reason.
The preceding program was brought to you by Stanford on iTunes U and is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at itunes.stanford.edu.